Hello and welcome to Filibusters in Fine Print, where AMGA's public policy team gives you the insider view on healthcare regulations and legislation. Thanks so much for joining us for the latest from Washington, D.C.
Good morning and welcome to Filibusters in Fine Print, AMJ's public policy podcast, which also focuses on regulation, as I look at Mr. Drevna this morning. Hope you all are doing well. Why don't we introduce our expert panel for the day, and then I will lead with the title of today's podcast, which will capture everyone's attention right away. So why don't we go to the right this time?
Jamie Miller, Ambassador Goodwill here at AMGA.
Hi, everybody. Daryl Drevna, Senior Director of Regulatory Affairs.
Lauren Latney, Director of Government Relations.
Alicia Sawyer, Government Relations Assistant.
Wow. You can tell we have a 4-page outline because everyone just sort of ran through their titles.
We don't have time.
Yeah.
We literally do not have
How you feeling today? Good. Sort of. Okay, got it.
It's like, okay, never mind. All right. So today, I'll give you today's title of the podcast, and our listeners can decide if they're going to stick around or not. Are you all ready? Today, CMS's contract year 2027 Medicare Advantage and Part D proposed rule, released November 25, 2025. I'm at the edge of my seat.
You're tongue-tied.
Coffee right there.
Yep.
Right at the edge of my seat. But despite the title, buried in this rule is a request for information asking questions about basically revamping the entire Medicare Advantage program. So this rule is actually very important for what it also covers besides the usual contract year stuff.
Absolutely.
Is that right? Okay.
Yep.
Good.
Absolutely.
I tell you, why don't we go to Alicia first? And Alicia, can you give us some key context to this rule?
Of course. MA now covers over half of Medicare beneficiaries. Plans are facing unexpected cost pressures. AMGA members are experiencing significant payment reductions. And the Trump administration is in the midst of pushing for aggressive deregulation. And so in line with that, CMS is signaling through this RFI, is the current MA model sustainable? They want to improve quality and access to care, streamline enrollment, encourage competition in the MA market, and modernize regulations. Comments for this RFI are due January 26, and this is a critical opportunity for AMGA members to weigh in.
Yeah. All right. Thank you. This is a remarkable request because they are really opening up almost every aspect of Medicare Advantage and how this administration can improve it in their eyes. So this is a really important thing. The big question is the future of MA. Daryl, you did ask me to talk about this, but I think this is really up your bailiwick. So why don't you talk about what is CMS asking for here and where is it they're asking?
Sure. So buried in this proposed rule, if you want to look at the the copy that before it hit the Federal Register, pages 326 to 336, there's an extensive request for information. I should start off with CMS explicitly states they're not going to formally respond to whatever suggestions or comments organizations or folks submit, but they're going to use this input to, quote unquote, shape the future of rulemaking and potential innovation center test models within the Medicare Advantage program. So what does that all mean? CMS knows the current system has problems and it wants fresh thinking on Medicare Advantage. And I think there are three real big areas in MA policy that they're going to be particularly interested in hearing from everyone. And I think we could take these in turn. There's risk adjustment reform, star ratings, and quality bonus payments, and then promoting well-being, prevention, and nutrition.
Okay.
So it's a lot.
We hit the first one?
Sure, yeah. How deep would you like me to go on Medicare Advantage risk adjustment?
We have 45. You put in your outline, this is a 45-minute podcast.
Right.
So we have lots
Volume
of
1.
It's like the Avatar movie. 4 hours. We're going to go.
Get a billion streams down.
Could I confess something? I've never seen those.
Okay, come on.
They're
kind okay.
I've been on the ride at Disney several times, but
enough.
this is cool. But I don't get the reference. So anyway,
They're just really long movies.
really long movies. Yeah. Okay. risk adjustment. So I'm going to assume everyone knows what risk adjustment is, how it works in Medicare Advantage versus MSSP. I'm getting a lot of yes, we absolutely know.
Are you kidding?
Yes, of course we
yeah.
do. So
Came
I'll
up
cut
with that.
right to the chase, and the problem is the current CMS HCC risk adjustment model is facing a host of criticisms about how there's gaming and inaccuracy in the program, and the way it's currently structured, CMS and outside stakeholders are concerned that plans can potentially inflate diagnosis to boost payments, and they're just creating this perverse incentives. To address this, CMS tried to phase in this new model earlier, but the rollout's been pretty rocky. We pushed back on this and urged CMS to delay the model phase in. And one of the reasons why is we thought CMS's new model was going to be inaccurate, and our members were reporting to us that plans were already cutting benefits and reducing provider reimbursement in anticipation of this new risk adjustment model. So this could create a direct hit to physician practices and ultimately patient care. So now, sort of based on all this feedback and this environment that's going on with concerns about risk adjustment, CMS is asking for ideas on improving the accuracy and fairness. So this just isn't a technical change to the rule. This is really CMS looking for how are we going to reimburse plans, which in turn directly influences how providers are going to get paid. So getting this right is of critical importance for not only the sustainability of the Medicare Advantage program, but ultimately physician and our groups and systems reimbursement under this model.
I think you are absolutely right, and look forward to hearing the members' input on this because it is critical. Okay, you mentioned star ratings and quality bonus payments. Jamie, can you talk about that a little bit?
And that system's currently under a lot of scrutiny. And just to warn everyone in the room, be prepared. Daryl's going to be very proud right now. On page 238 to 254 in the unpublished rule is where all this information is.
Wow.
Yeah.
Did you find this?
Yeah. Well, it was in the.
Okay.
No, he didn't write it. I
Well,
found it.
well done. Well done.
There you go. Okay, I'm done.
It's
Now-
the little things.
It's a little.
That would be the fine
I'm
print.
trying to be more
That
human
would be
on
the
stuff.
fine print. He looks so proud.
Wait, you can stop right
The
now.
little things,
So they're going to remove 12 star rating measures effective 2027, but also add a depression screening and follow-up measure. And they're going to remove a health equity index reward and continuation of the historical reward factor. So, but as Daryl mentioned, also there is an RFI on the bonus payment star rating systems, and there's a lot of questions about ways to shorten the timeline for adding new star rating measures, whether CMS should test an innovative model that delinks these bids and measures, also advantages of alternative models. So there's just a lot of, as Daryl mentioned, a lot of just discussion in this RFI about the future of Medicare Advantage.
All right, and so it looks like CMS is, maybe rethinking quality measurement. I know we have our own measurement set that we have pushed since since 2017, perhaps, under the old Hines Commission.
Yeah.
So I think AMGA's view is that less measures focused on outcomes is a much better way to go than 500 process measures, either in traditional Medicare or Medicare Advantage. Is that fair to say?
Yep. 100%.
Okay, so that's what we're talking about, I think, in our response,
Yep.
right?
Yep.
Good.
Already started writing it.
I'm sure you have. All right, Miss Latney,
Yeah.
we'll talk about well-being prevention and nutrition.
Yeah, this isn't a shock. Secretary Robert F. Kennedy Jr. has been really emphasizing the MAHA agenda. And so we're seeing in its RFI them asking for stakeholder input on policies to improve emotional well-being, nutrition, strengthen MA's organization to invest in care that promotes long-term health and looking at mitigating chronic diseases. So the agency is basically requesting requesting input on tools and policies to improve emotional health, social connections, purpose, and fulfillment. They're also looking for feedback in terms of how do you integrate these things within an MA framework. They're also introducing a separate RFI that focuses on optimal nutrition and preventative care among MA enrollees. It may include strategies, guidelines, and practices designed to promote healthy eating habits and ensure individuals have necessary nutrients to maintain health, growth, and overall well-being. This is sort of a common theme, right? What are the financial incentives that could be due here? And also it falls under, again, the MAHA agenda. We saw just this week the rollout of the new dietary guidelines for Americans. So this all sort of flows together. To summarize, it's eat more meat, drink whole dairy, eat fruits and vegetables, and don't drink as much.
Is that right? Don't drink as much?
Yeah.
Oh.
Yeah.
I mean,
No processed stuff too, right?
Oh, yeah, no processed food. But I figure, wine is processed food.
It's a beautiful process.
It's a beautiful processed food that
Everyone's
we're not
nodding.
supposed to limit. Now we're supposed to limit. So, incorporate more healthy fats and all of that. So you're just seeing that all be fully
Beer's a
incorporated.
fat, isn't it?
It is. Is it? No, beer is a carb.
Yeah, but
that
if Total Wine,
bad.
if Total Wine is listening, please
Carbs
Yeah,
are at the
sponsor
bottom.
our podcast.
Yeah,
Not by
carbs
Total
are
Wine.
at the bottom now.
Carbs are,
Yeah,
bad.
Yeah,
carbs are
they
at the bottom.
flipped it.
Carbs are bad?
So eat a lot of steak.
Red steak, no pie.
Yeah.
What?
What about red steak pie?
What do we eat?
That's
British
like-
now?
Yeah.
Yeah. Which we drink with beer, which is high in carbs. So we're kind of going away from the guidelines.
Oh, really?
Yeah.
Shepherd's pie. That's
Okay.
Shepherd's pie.
So yeah, a lot more focus on
Sounds good.
nutrition
Sounds
and
good,
chronic
I think.
health and how those all kind of interlace together.
Oh, fair enough. Okay, so we just talked about CMS's RFI around sort of revamping the entire Medicare Advantage program, potentially. But there is a lot of congressional scrutiny on the Medicare Advantage program as well. They've looked at this. Daryl mentioned risk adjustment. I think Congress is also concerned about risk adjustment. There is a No Upcode Act, which was sponsored by Senator Bill Cassidy, who has real concerns and skepticism over risk adjustment methodologies in MA currently. Let's talk about the No Upcode Act and where Congress is headed over MA oversight as well. Jamie?
So when it comes to the Cassidy bill, the No Upcoding Act, he's worked with various senators about trying to develop the risk adjustment model that uses 2 years of diagnostic data instead of 1 year, limiting the ability to use old or unrelated medical conditions when determining the cost of care, closing the gap between how a patient is assessed under traditional Medicare and Medicare Advantage. And why this is important is that it could save over $100 billion in the system over 10 years. But we've been talking with Cassie's office, and obviously there's some House members as well who want to reform the Medicare Advantage program. We just we want to make sure, and I think the senators understand that if you make these adjustments to Medicare Advantage and it's not done carefully and specifically, you could really impact patient access to care. So that's been our work with Congress. I would say also Congress has been working on other issues like prior authorization or the WISER model, which we've been concerned with. There's actually there's been consideration in a House committee about repealing the WISER model. And right now the WISER model only impacts 6 states, but it will go national eventually. And that's going to be something you'll be hearing from members of Congress on it today and in the future as well.
All right. Yes. So Congress is looking at Medicare Advantage in a very strong way. Yeah. Okay. So Daryl, there is a provider perspective to all these potential changes as well, is there not?
Absolutely. This is something we've been working on for, several years. And I think if you take a step back, one of the things we hear from our members a lot is the need for programmatic and regulatory stability, right? They want these programs to function as best as they possibly can. But it's when you keep tweaking this model, or we're going to put these codes into the HCC. Now we're going to take them out. We're going to roll this out over a couple of years. This takes me back a couple of years to the encounter data issue. It's like, we're going to use this encounter data. No, it's going to be the RAP score. And it is like, the phone will ring and I'll be like, Daryl, what did they doing, and how long is this going to go on, and can't they just pay me for the work we're doing, fairly and accurately? And I was like, you should come to DC and spread that message. So it's that instability and uncertainty more than the technical aspects of a particular risk adjustment model that really animates our members, I think. It's that, and we mentioned this in our comment letter a year ago, January 25. These model changes create financial unpredictability, and then if planned payments to the plans drop, ultimately payments and reimbursements to the provider is going to drop, and these ramifications are quickly going to go further downstream and impact patients. So that's really, I think, from the provider perspective, it's create a system, let it go, and so we can plan around it.
Yeah, I agree. I think the members found Medicare Advantage popular. I guess that's a word we could use. One, because that's where their patients were going, and two, because compared to traditional Medicare, it was a stable financial platform with sort of a limited set of rules,
right,
as opposed to traditional, and that's why they entered it. That's why they liked it, were good at it, and also incentivized care coordination. And now we're almost seeing MA replicate traditional Medicare in the fact that you have rules going up and down, back and forth, and it is. There's a lot of stuff going on with Medicare right now. Okay, so there's a tension, and there's a tension between rising costs, pressure to cut provider payments. Our members are caught in the middle. Where are we with that tension?
It's a bipartisan tension. It's both sides have looked at MA and decided that, it's kind of yucky. We want to look at this further. What that looks like in terms of what the legislative output beyond the No Upcut Act is, it's still TBD. I think there's still discussions when you're dealing with a bipartisan thing. Everyone's still coming from their separate corners of policies here. But you're seeing rising costs, you're seeing pressure on cuts to provider payments, and you're seeing this pressure that providers are experiencing, which is what Daryl has outlined. And so we have always taken the position of fix the risk adjustment, don't destabilize the program further, doing follow-ups in office after doing in-home evaluations. So we have always been sort of firm on that. But Congress is still sort of twisting around on it, I think, a little bit. There's conversations that are happening, but they're not as substantial as we think they are. But that might change if people need a couple $100 billion quickly.
Yeah, that's right. That is, absolutely.
And I think when it comes to risk adjustment, we're hearing from a lot of members of Congress who are asking perspectives of MA plans, and there isn't consensus among the MA plan community about what direction on the No Upcode Act they should go. And I think the positive thing we should take from that is, why I always try to be positive, is that the people writing the legislation want the input from you, the provider. So there is currently written, MA Upcode Act is not something that's going to pass, but there's something similar. And you talk about bipartisan support, Lauren, concern. There used to be a letter every January, February when the MA call letter would come out. In February, Daryl? Yeah.
Yep.
And every February there'd be 150, 200 House members, probably 75, more than that.
400
sometimes. Yeah. And then actually there was 500. There was more of the House members that exist. It was amazing. Yeah. But also that the Senate, yes.
Population
people
change.
Say there are 700 members of Congress, but
they're 700 years old.
That's the Senate.
There's a lot of support, and basically the letter always said, we support MA, don't hurt MA beneficiaries, don't hurt the beneficiaries, but those letters are not as common as they used to be.
Indeed. All right, so we have CMS. Yeah. Actually, I just got the wrap-up sign from Daryl, which means I need to just focus on Daryl's stuff. Okay, so quickly, Alicia, what should AMG members be concerned about?
I think our 2025 comment letter paints the best picture, and it's not a beautiful one. Not that Daryl's writing isn't beautiful.
Let's be clear.
It's beautifully created. It was a stark image. How's that? But A direct quote, as I've been given, is AMGA members are experiencing significant reductions from Medicare Advantage plans. And what we're seeing in those reductions are plans are eliminating benefits with direct effect on patients at the same time that provider organizations are facing staffing reductions, program eliminations, strategic plan overhauls. And to close myself out, another direct quote, the effects of these changes will not be restricted to the plans or the insurance industry. It will be felt by patients.
And absolutely. Okay, speaking of closing out, Daryl, why don't you close it out with some final thoughts around this?
Sure.
This is a big deal.
Yeah. So I think this is a really big opportunity for AMGA and our members to really have some influence on the future direction of the Medicare Advantage program. But one of the things to also keep in mind is these changes aren't happening in isolation. If you caught our previous episode, there's a whole lot of extenders that need to get reauthorized. There's conversion factor and Part B changes. And whereas regulators in Congress tend to look at these things in isolation, we as an organization don't. We take a larger picture of that. And I think that's why when we respond to these RFIs or these comments or draft legislation, we'll come in with some technical comments and technical suggestions, but also we always have in the back of our mind, what is the bigger picture here? How does this fit into the larger system? So if you're an AMGA member listening to this, keep in mind we don't look at this just as a fix to a Medicare Advantage risk adjustment. It's like, how does this work in conjunction with Part B reimbursement or things on post-acute care, and how are we going to make the system work as seamlessly as possible so you can deliver the best care you can.
All right. I think it's a good way to end. Daryl, you'll be very busy. The whole team's been very busy with some of the work on Congress. So Medicare Advantage is in the crosshairs, ladies and gentlemen, and we're on top of it, and we look forward to working with all of you and getting your input on how we can best represent your views in front of Congress and CMS on this. And with that, I guess, are we done? All right. With that, Daryl says we are done, so we're done. Thank you all for listening, and you all have a very good day.
Thanks for joining us for Filibusters in Fine Print. This podcast was brought to you by AMGA. For more information about AMGA's advocacy efforts, visit amga.org/advocacy.